I am so incredibly honored and thrilled to introduce Dr. Kayla Matilde Lopez. Dr. Lopez is Associate Professor of Pediatrics in the section of Pediatric Cardiology at Texas Children's Hospital and Baylor College of Medicine. She's a Chicagoan by birth who completed medical school at Rush and residency at the University of Chicago, where she served as chief resident during my time as a medical student there. She completed her MPH at Harvard in minority health policy and healthcare management, and her fellowship in cardiology and cardiovascular imaging at Baylor College of Medicine, where she and I were then co-fellows and shared an office for 4 years. She has spent her career studying health disparities and advocating for public health initiatives, and has been a champion in this space for the better part of a decade. She directs the Pediatric Cardiology Transition Program and has an NIH Early Career Award to use technology to reduce health disparities during the transition process in patients with congenital heart disease. She's participated in several community and national initiatives to help underserved population, and most recently was the only Latina and the only pediatrician appointed to Houston Mayor Turner's COVID-19 Health Equity Response Task Force, and it was all over the news. Dr. Lopez seeks to incorporate cardiology, public health, and minority health policy in order to develop research initiatives that directly inform health policy and improve healthcare of minorities and underserved populations. She is a dynamic and inspiring speaker, and I love the title of her talk, inspired by the late, great John Lewis, Good Trouble, the Pursuit of Health Equity in Pediatric Subspecialty Care. Dr. Lopez, take it away, and thank you so much for coming.
Thank you so much, Dr. Muscatic. I'm so thrilled to be here, and I'm actually really excited to be here in person. So this is a big moment for me. So thank you very much for the opportunity. I have no disclosures. So I wanted to start off with talking about the meaning of good trouble. So Representative John Lewis is best known as a civil rights movement pioneer. He is one of the big 6 civil rights leaders alongside Dr. Martin Luther King Jr., he was one of the organizers behind the 1963 March on Washington. He spoke at the same rally as Dr. Martin Luther King's historic I Have a Dream speech, and he was elected to Congress in 1986, serving from January 1987 onwards as a representative for Georgia's 5th district. And he sadly passed away in 2021 of pancreatic cancer, but he was an orator unlike many others. His words galvanized action for multiple generations. And so I used the inspiration of his words to inform some of the pediatric principles that I think about when thinking how to change outcomes and reduce inequities in pediatric chronic disease populations, in particular congenital heart disease. So his first quote here is, "Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day or a week or a month or a year. It's the struggle of a lifetime." And I feel that those words are often true for pediatric chronic disease survivors. Never ever be afraid to make some noise and get in good trouble, necessary trouble. And so I took a few of his quotes to kind of inform some of the principles of this talk and really what I use on the daily. So the first is, freedom is the continuous action we all must take, and each generation must do its part to create an even more fair, more just society. And so from that, I take away, understand where we started in medicine to target where we are going and what is possible. Because if you think about in our own field of congenital heart disease, we've come a very, very long way from really thinking about survival to thinking about now quality of life. The next quote is, when you see something that is not right, not just, not fair, you have a moral obligation to say something, to do something. Our children and their children will ask us, what did you do? What did you say? And so from this, I take that kids that we serve are natural risk takers. They're people who question and who often voice injustices. And we should frankly follow their lead to make bigger impacts in serving them. Never let anyone or any person or any force dampen, dim, or diminish your light. Study the path of others to make your way easier and more abundant. And from that, I take away, embrace collaboration, innovation, and interventions to advance health equity, even in subspecialty pediatrics. And then lastly, we will stand up for what is right, for what is fair, and for what is just. Healthcare is a right and not a privilege. And I believe that we need more voices to translate research, education, and QI into effective health policy in pediatrics, particularly to reduce health disparities. So with that, I'm going to give a little talk about the following. First, we'll talk about applying these good trouble principles to pediatric care. Second, understanding the history of health inequities in terms of medical mistrust in communities of color. Then we'll learn some lessons from subspecialty pediatric equity leaders. We'll describe some health equity research in the subspecialty fields to impact pediatric chronic disease populations. And then we'll talk about learning to translate your voice into health policies to reduce pediatric health inequities. So when I was in public health school, there was an answer that came to a question that I asked that actually changed the course of my career. The question that I asked was, why would anyone vote for a policy or a health policy that could potentially harm children? I just couldn't believe that someone would actually vote for something that could do some harm to people that are so helpless, so vulnerable. And the answer that I received was pretty profound to me. The answer was because kids can't vote. Kids cannot vote for what impacts them. And so this led me to understand that as pediatricians, we are the voices of children for the policymakers in Washington and the state and local policymakers. And that if our awareness and our data and our ability to kind of bring up good trouble or kind of bring up issues that maybe other people may not bring up and issues that need to be brought to the forefront are what allow for us to have an increased focus on public health, to increase research dollars for interventions, and to create health policy change. And these are all things that are really, really necessary in the pediatric space, right? Because we're the voice for the children. And pediatrics and pediatricians actually define good trouble. So pediatricians have been doing good trouble for a very long time. They have been doing public health initiatives and optimizing health and wellness of children for example, the American Academy of Pediatrics. We've been talking about opposing separation of children and their parents at the border, and that's good trouble, because we knew that that would do harm to the psyche of children and the long-term effects of that. We've been talking about national emergency in child and adolescent mental health amidst the COVID pandemic, as well as the impact of racism in child and adolescent health. And so these are things that actually define pediatrics. Good trouble actually defines pediatrics and pediatricians. And so this is what I went into pediatrics for. This is what drove me to go into pediatrics. But therein lied the disconnect. When I decided to go into pediatrics, I wanted to go into subspecialty pediatrics. And the disconnect was what I was told. I was told that public health advocacy and these health equity pursuits that I dreamed of were the job of a general pediatrician. That as a subspecialist, that wasn't really what I was supposed to be doing. I was supposed to be focusing on more distinct research and not really on these advocacy efforts, because general pediatrics took care of that. So it took me a while to figure out my voice in this subspecialty space. So my journey to finding my career path had a lot of pauses. So I started at the University of Illinois in Urbana-Champaign, where I majored in the obvious choice of Portuguese, because I wanted to make sure that I could communicate with various individuals from various cultures. I then went to Rush University Medical Center. I was born and raised in Chicago. And so going to med school on the west side of the city really informed a lot of the communities I wanted to serve, a lot of underserved communities there, a lot of Latino populations there. But during med school, I felt like something was missing. Like I was getting a lot of information on how to help people one-on-one, but something was still missing. And so at that point, I went to the Mayo Clinic and I learned about clinical research for the first time, and about how I could use clinical research as a tool to inform outcomes for patients and to make a bigger impact. And that was really exciting. And that subsequently led to my going to a residency at the University of Chicago, Coleman Children's Hospital, where I primarily served children on the south side of Chicago. The south side of Chicago is one of the most underserved areas of Chicago. And at that point, I matched in pediatric cardiology towards the end of that, my chief year there. But there was still something missing. I still felt like I had to do something bigger, and I couldn't really put my finger on what that was. And I had the opportunity that came across my desk at that time to do a Commonwealth Fund Fellowship in Minority Health Policy at the Harvard School of Public Health. And that was the moment where I learned a lot more about the things that would instruct the work that I'm doing today in terms of health equity and advocacy. But after that point, there was this major roadblock. And I was told, well, if you want to do health policy and you want to do advocacy and health disparities work, you probably need to do something like asthma or obesity, because those are the areas that we're mostly impacting in those spaces. And thankfully, I had a very smart program director at Texas Children's Hospital who said, actually, we need a lot of health disparities work and public health work in pediatric chronic disease, like congenital heart disease. It's not just general pediatrics. And so therein lied the opportunity for the least of these, for the populations who are the most underserved, the populations that have the highest degree of chronic disease, for the low-income children with chronic diseases who need more voices to advocate for them. And so it led me to understand that pediatric subspecialists are actually ideal good trouble partners for general pediatrics and pediatricians who have been doing this job for a very, very long time and who we have learned from. And that data and advocacy are the things that drive policy. And making policy change are what we need to do to impact pediatric populations. And so I wanted to give a little bit of the history of health inequities in terms of terms in medical mistrust and community of color, so we can kind of go on this journey as subspecialty pediatricians. Most people have seen this series of panels. This is the difference between health equality and health equity. And you can see that in the first image, this assumes that everyone benefits from the same support. So these people are all trying to watch the soccer game. And you can see that there's a barrier between the individuals trying to watch the game, the soccer game, and everyone is given the same support, but the person on the left can see the game, and the person on the right, despite given the same support, cannot see the game. In the middle is equity. So everyone's getting the support that they need. So everyone is able to see the game, and even though the person on the left received no support, they can still see the game. The person on the right received a lot of support, and now they're able to see the game. So they started at different places. And then finally, there's justice. And this is the third image where everyone can actually see the game without any supports or accommodations because the source of inequity has been addressed and the systemic barrier has been removed. So the question is then what created or what has created some of these barriers that require people or that give people this different starting place and require kind of differential treatment for people to get to the same outcome? The answer is that systemic inequities stem from racism. And racism comes in all different forms in different sectors, including housing, criminal justice, public health, education. And there's at least 4 different types of racism: systemic, institutional, interpersonal, and internalized. And for the purposes of this talk, I'll be primarily focusing on structural racism and institutional racism, but I encourage you to look up those other 2 terms because they're also very important. So structural racism is in many ways known as systemic racism, and it's the silent opportunity killer. It's the blind interaction between institutions, policies, and practices that inevitably perpetuates barriers to opportunities and racial disparities. Institutional racism occurs within institutions and systems of power, and this refers to the unfair policies and discriminatory practices of particular institutions like schools, workplaces, etc., that routinely produce racially inequitable outcomes for people of color and advantages for white people. So I'll give an example. In 1933, the United States Congress created this homeowners loan corporation because there was a lot of foreclosures as a result of the Great Depression. And this agency was tasked with providing new low interest mortgages to both homeowners and private mortgage lenders. So between 1933 to 1936, the agency serviced about 1 million households, and the outcome was the creation of infamous residential security maps that categorized city neighborhoods into 4 grades. This is the map of Philadelphia, and the grade A neighborhoods, or the green neighborhoods, were the best neighborhoods. They were the most ethnically homogenous. In other words, they had the highest degree of Caucasian populations, and they had room to be developed, lots of land. Grade D neighborhoods were considered hazardous and were colored in red. And these neighborhoods had low home ownership rates, older housing, and people who lived in these areas were thought to be at the time undesirable. And those were largely referred to as Jewish Americans and African Americans. And these maps kicked off the systemic mortgage discrimination in America's neighborhoods known as redlining. It was the practice of denying credit to people who lived in these red areas, in these undesirable neighborhoods, and that resulted in more people of color having less equity, less types of funding, less good schools, less quality grocery stores, less pharmacies, less access to care. And when you coupled that with interpersonal racism, it increased their unemployment, which often meant decreased access to health insurance and worse quality healthcare. So people say, well, you know, that was a long time ago. That was almost 100 years ago. It probably doesn't impact to this day. The answer is actually, it absolutely impacts us to this day. And in fact, in Houston, if you're a child who's living in the 5th Ward, which is a predominantly African-American community, your likelihood of having cancer is 5 times that of a kid in any other area in Houston, simply because of some of these practices. Because what is in those areas that are redlined, those are where the toxic waste dumps are, those are where environmental pollutants are, etc. And so these redline districts have really created a large shift in what people's healthcare outcomes have been. So it turns out that your zip code matters more than your genetic code. Life expectancy is an overarching health indicator for any population. And since we're here in Palo Alto, I thought I'd show a map of your own area. So this is the map of of the areas in and around Palo Alto, and the colors in this map represent racial and ethnic groups. And I'm guessing that people who live and work in this area can guess who it is that lives in East Palo Alto. So the colors here represent different races and ethnicities. And we'll get to that in just a second. So first, the average life expectancy in someone born in San Mateo County is about 75 years. But if you look at East Palo Alto, where the majority of the populations are Latino, the average life expectancy is 62 years. So that is an average life expectancy difference in 13 years. And that's obviously a major difference between East Palo Alto and the rest of the surrounding areas. The rest of the surrounding areas, as you can see, are predominantly Caucasian and or Asian. So this matters because in East Palo Alto in 2010, the violent crime rate was nearly 80% higher than the rest of the state of California. Residents cannot afford to go to the gym or to buy bicycles. Things such as walking or running are difficult because many parents work 2 or 3 jobs to make ends meet. And in the city, this is a city with a lot of children. Those under the age of 19 make up a greater percentage of the population than the rest of the county average, about 35% versus 24%. And so if you're a child living in this area, your likelihood of being hospitalized for asthma is double that of the county rate. And this is not something that's specific to East Palo Alto or someone here. This is actually something that we see in many other cities. And in fact, in my own city of Chicago, we have the highest life expectancy gap in the country of 30 years. So if you live on the north side of Chicago, you are more likely to live 30 years longer than somebody who lives on the south side. And this is pretty important because it kind of speaks to the fact that these conditions, when we're talking about the causes of these disparities, it's not one single cause of disparity. It's not one thing that's causing a difference. These disparities are driven by at least 4 key factors, including socioeconomic inequalities, access to healthcare, the quality of healthcare, and of course, preventable health issues. So when you're trying to figure out how do you term those, or how do you know kind of where to put what buckets to put those in, those go directly into what we call the social determinants of health. And these are conditions in which people are born, grow, work, live, and age, and a wider set of forces and systems that shape the conditions of our daily lives. And so the disparities in the social determinants of health among minorities put them at risk for poor outcomes from a variety of different diseases. And so if you live in a neighborhood where you can't exercise, you're more likely to be obese because it's not safe, or you don't have a walkable area to walk in, or playgrounds, because those areas, again, were the red line areas that had less funding for those things like parks, schools. If you have less good schooling, you have less education, you have less economic stability. That means you have more debt, and including more medical bills, more debt, more unemployment, less good quality foods, more food deserts, etc. And so this became particularly obvious during the COVID pandemic, when people realized that the differential outcomes were directly due to some of these differences in the social determinants of health. And really, the COVID pandemic blew the lid off of some of the inequalities in the social determinants of health that have existed for a very, very long time. I also wanted to bring up one other area that people often don't think about, and that is digital inclusion as a social determinant of health. Digital literacies and internet connectivity have been called the super social determinant of health because they actually address all the other social determinants of health. For example, applications for employment, housing, assistance programs, getting on insurance, a lot of these things are increasingly available only online. And that, therefore, you have a greater reliance on digital tools. And this has the potential to increase disparities between those who have skills to access digital tools and those who do not. And so if you take all of that background, and then you layer on top of it some of the historical things that have happened to communities of color, you kind of start to understand why there's so many disparities that exist, and why there's such a hesitancy for some of these communities to trust academic medicine or academicians, or even people who are doing research in these communities. So this high level of historical distrust in minority communities that exists is for good reason. So most people are familiar with the Tuskegee experiment, and that's in the early 1930s, when over 600 African-American men from Alabama were enlisted to partake in a scientific study known as the Tuskegee Study, and they had no idea that they were being enrolled in a study that was just watching what happened if you didn't treat syphilis. And so they were not told for years that they were not being treated. Some of them were getting what they thought they were getting medications, they were getting placebo. They ended up infecting their partners, they ended up infecting their children. And what's even worse is that this experiment lasted for more than 6 years. And so obviously extremely unethical. But this is not the only example of some of these unethical treatments. When the United States started coming up with birth control pills, they wanted to see what the outcomes were of women who took birth control pills, but they didn't want to do it on the mainland in case something went wrong. So they actually took it to Puerto Rico. They said, okay, let's try these birth control pills in Puerto Rican women, mostly of whom were disenfranchised and poor, and had no idea that the med that they were taking was experimental. They knew that it might help them to not get pregnant, but they didn't know of any of the potential side effects. They were never told. Many of them actually ended up having really untoward side effects, blood clots, et cetera, and dying. And many of their deaths were never investigated. Most people have heard of Henrietta Lacks, whose cancerous cells and medical records were used for research without her knowledge or consent. And none of these profits from biotechnology companies were passed back to her family. And currently her family is actually in court requesting reparations from all of this. So people say, you know what, that was a long time ago. That was the 1930s, 40s, and 50s. That's why we have IRBs, so that things like this don't happen anymore. Well, as recent as the 1970s and 80s, there were eugenics programs in the United States that actually forced sterilization of Native American women. These women thought that they were getting appendectomies in the 70s and 80s when actually they were getting tubal ligations. And it's estimated that as many as 25 to 50% of Native American women were sterilized in the early 1970s without their consent. So again, people say, well, that was in the 70s and 80s. That's not happening nowadays, thank goodness. As recent as the summer of 2020, women that were in US Immigration and Customs Enforcement, primarily Latinas, were getting hysterectomies without their consent. They were being sent off to this offsite gynecologist. They were being told that they were being evaluated for kind of being housed in these facilities, and they were being given hysterectomies. They were being put under anesthesia and given hysterectomies without their consent. And so thankfully there was a whistleblower who figured this out, and they blew the whistle on this entire operation. And a lot of these ICE detention centers were shuttered as a result of this. So you can imagine that this long history makes it harder for communities of color to trust when there's a new vaccine, when there's a new medication, and depending on who is giving them the messaging, it makes it harder for them to trust as well. But the problem is actually bigger than just this history, right? So people talk a lot about, oh, well, in communities of color, the reason that they don't want to get the COVID vaccine, they were anti-COVID vaccine, is because of Tuskegee, because of experimentation. The reality is that that's not the biggest reason why African Americans and in the end Latinos were not getting access to vaccines at the beginning of COVID. The reason was that they had no access. Most of the people that were getting their vaccines were from pharmacies. Well, there were no pharmacies in some of these red line districts. The nearest pharmacy was 2 or 3 bus rides away. And a lot of them couldn't get to their physicians, to their primary care physicians, because they are also far away. So it has a lot more to do with access than it did with attitude. And the same thing was true for Latinos. Latinos had the highest percentage of individuals that were getting disinformation about the COVID vaccine. They were being told that it was going to sterilize them. It was all over all Latino social media. And so for this reason, when we think about how are we going to engage these populations and how are we going to make a change as subspecialists, our voice matters because we are able to engage with these communities. We have a lot of contact with these communities and these patients. And so community engagement is key. And Dr. Kim Rhodes, who did the same program that I did at Harvard a couple of years ahead of me, she is a colorectal surgeon. And her background is as an associate director for community engagement at the UCSF Helen Diller Family Comprehensive Cancer Center. And her whole career is focused on disseminating information to the community and engaging communities in their own treatment, in facilitating workshops and events, and in advocating for these individuals. And so this community engagement is really critical and key for subspecialists to get involved in, to be able to help with some of the research opportunities and some of the research projects that we're doing, because without this community engagement, we don't have the same outcomes. We don't have the same involvement. We don't have the same interest from communities of color. And so it's critically important for those of us in subspecialty care to do this. So what does DEI work look like then if you're trying to engage communities? What does that mean? So I wanted to come up with I wanted to describe a few terms that people have heard of, but that people tend to use synonymously. They're not synonymous terms, but they do all fit together. So first, the term diversity. So diversity between people can be understood as the presence of a difference. It's really just that simple. This can refer to people of various races, genders, sex, socioeconomic status, sexual orientation, etc. And when applied to an organization, oftentimes when we talk about diversity, we're talking about cognitive diversity or diversity of ideas. Diversity is at the core of inclusion. And inclusion means that people with marginalized identities feel as if they genuinely belong, that they are valued and relied upon, and that they're empowered, and that ultimately that they matter. So like diversity, inclusion is an outcome and often an actual experience of the workplace, and one that holds real potential or implications. Equity we've already discussed. And in many regards, I think what we have to understand about equity is that it allows for everyone to access the same opportunities. And it requires that people understand that there are unequal starting places for equitable care. People don't all start at the same place. And then finally, belonging. Belonging is the outcome of holding space where everyone truly feels empowered to speak up, make change, and shift the culture. And it is the responsibility of those in the dominant social culture to create these conditions. So what happens if you're working with communities and you're working with research and in different initiatives in terms of getting within the community and doing things, and you have some of these, but not others of these? Let's talk about it. So first, situation number one. This is where you have equity and inclusion, but no diversity. This is what I like to call hashtag so many white guys. So this is where you have a boardroom full of white men. It's kind of like an episode of Mad Men where you walk in, everyone looks the same. And I think this is what things look like a lot in the 80s and 90s. And I think that has changed a lot. And now boardrooms tend to look more diverse. Situation number two is where you have inclusion and diversity, but no equity. And this is the one that I like to call hashtag the power struggle. And this is where you have these kind of bold, progressive community organizations that are excited to advocate and change and help change communities and policies. But those in the positions of power or leadership do not represent the diversity of the community that they are trying to serve. And in fact, some of the beliefs that they have are that of the dominant social ideology and not aligned with the actual desires of the populations that they are trying to change. Situation number three is arguably maybe the worst one, and that's where you have equity and diversity, but no inclusion. And this is the one that I like to call hashtag I heard you but. So this one is an erasure of experience and perspective, but it can be subtle and dismissive. So let's say I, for example, as a Latina, am invited to walk into a boardroom. And of course, as the only Hispanic person that's there, I'm expected to speak on behalf of all Latinos, despite the fact that we come from different countries and different cultures. I'm there as a representative. And I give thoughts and ideas, and everyone says, oh, that's nice. And then my idea isn't considered until a peer of mine, a white male peer of the dominant culture, says the exact same thing that I just said about 15 minutes ago and takes my idea as his own, even though I've said this idea multiple times in the past. And so it's important to recognize how some of these situations and scenarios are actually applied to populations that we're serving, to research studies that we are doing. Are we thinking about the populations? Are we including them early on in initiatives that we're doing? Are we including them early on? Are we listening to their voices? Are we understanding their desires before we get involved with their communities in research opportunities, et cetera? So when I think about some of the ways that we have involved communities in care, I wanted to talk a little bit about the lessons learned from some subspecialty pediatricians that are equity leaders, because again, it's not as common to see. Before I do that though, of course, I have to talk about the long history of general pediatricians as health equity leaders, because they really are the good trouble health equity leaders. And there's a few that are very, very obvious to the space that I'm in today. Dr. Paul Wise, everybody knows him. Obviously, a leader in child health policy and global child health, has been a huge advocate. Dr. Lisa Chamberlain, who has worked on transforming the way pediatricians practice by developing and disseminating models of community engagement, which is, as we discussed, hugely important, and conducting health services research to inform policy. Dr. Glenn Flores, whose work largely focuses on disparities for underrepresented minorities in the pediatric populations, as well as increasing the strategy for the pipeline for underrepresented minority physicians. Dr. Elena Fuentes-Affleck, who was just here for Grand Rounds, I was told last week, who works a lot in immigrant health and health disparities and the importance of diversifying academic medicine. And then someone that I work with at Texas Children's, Dr. Jean Raphael, who focuses on health policy and improving systems of primary care for underserved minority children with chronic conditions. So these are all leaders that we can take big lessons from in this health equity space. So I'd like to build a little bit on the DEI history in pediatric cardiology. So our entire, what we call herstory, was built on sponsorship as a field. So Maud Abbott, she's a Canadian. She's the only woman in her medical school class. She was not allowed to practice internal medicine because she was a woman. And she was invited to write the chapter on congenital heart disease by Dr. William Osler, who everyone knows. And he declared the best thing he had ever read on the subject, and went on to be one of the founding fathers of Johns Hopkins Hospital, and sponsored her to become essentially the world authority in the field of congenital heart disease. Dr. Helen Taussig, a woman who was refused admission to Harvard because they didn't admit women at the med school at that time, was admitted to Hopkins because of donations from the Women's Medical School Fund that was started by Elizabeth Garrett. And she launched a national campaign to raise an endowment for the medical school and said, hey, Hopkins, I'll give you a lot of money for your medical school. And they said, oh, great, hand it over. And she said, I'll hand it over once you agree to admit women and men on an equal basis at your med school. So that was pretty impressive, and a pretty impressive, remarkable sponsorship that she did. And Dr. Taussig's amazing research and imagination really helped, along with the help of another remarkable individual, Dr. Vivian Thomas. And his history, their history kind of melts together, but his history was that of a Black man who was not allowed to go to medical school, but he was a very skilled technician, and he was recruited to work alongside Dr. Alfred Blaylock. Dr. Blaylock was an incredible mentor to him and was a really great ally, and he was a skilled cardiothoracic surgeon who, between him and Dr. Taussig's idea on how to make babies less blue, they worked together to define the first BTT shunt, or Blaylock-Taussig-Thomas shunt. So between Dr. Blaylock's mentorship and allyship and Dr. Taussig's sponsorship of Dr. Vivian Thomas, they were able to figure out how to do this. And they did the first open heart congenital heart disease surgery. Now, this is Dr. Thomas here. You know, Dr. Blaylock wasn't perfect. Vivian Thomas was on none of the publications from this work, and his contribution to this work wasn't actually fully recognized until decades later, when he received an honorary doctorate from Hopkins University. But you can see him here in this picture. He's standing behind Dr. Blaylock, who's doing the surgery. At that time, African Americans were not allowed in the operating room, and Dr. Blaylock broke all the rules and insisted that he be there because Dr. Thomas had done all of the actual experiments on the dogs to figure out how to do these BT shunts. And so he stood behind him and told him exactly what to do. And because of that, we have the beginning of congenital heart disease surgery in our field. So that's a pretty amazing history for us. But since then, a lot of other subspecialists have done a lot of important health equity work. So building on the DEI history in adolescent medicine, Dr. Rachel Levine is a trailblazer in her role as the first openly trans federal official. And she was nominated and confirmed by the Senate in a bipartisan vote. And she's been bringing to light a lot of LGBTQ issues and issues about transgender individuals. And I will say, as a physician and a pediatrician who's working in Texas right now, her voice and her representation really matters in a state where they have just, the governor is trying to pass an executive order to make it that we cannot treat transgender children, because if we do, we're going to be labeled as child abusers. And so at this point, her voice matters a lot, and her representation matters a lot to help us kind of navigate these challenging waters in Texas to try to overcome this executive order, which currently has been halted by one of the state judges, thank goodness. Dr. Peter Hotez, major force, he's a pediatric infectious disease specialist, major force in research for vaccines, and as well as dispelling disinformation about vaccines. So he's been ahead of combating those in the anti-vaccine movement for a very, very long time. Him and Dr. Batazzi, another infectious disease specialist, created their own COVID vaccine for low socioeconomic status countries that are going to be actually able to afford the vaccine. And that is now being, I think it's close to distribution in those countries. And he also does a lot of commenting of anti-science. And so his daughter has severe autism, and he wrote a book called Vaccines Did Not Cause Rachel's Autism. And it was as a result of all of his advocacy and all of his work, he's actually now up for a Nobel Peace Prize. He was nominated for a Nobel Peace Prize. And so he's done a lot of incredible equity work as an infectious disease specialist. Even surgeons. So people think pediatric surgeons and surgeons like Dr. Rhodes that I talked about earlier don't have a lot of role in this DEI efforts. They have a huge role. And in particular, this surgeon, Dr. Ayla Stanford, is a pediatric surgeon that works in Atlanta. And she was actually named one of USA Today's Women of the Year in recognition of what she's done, launching the Black Doctors COVID-19 Consortium in April of 2020. So she's done a lot of community engagement and dissemination of information to address the racial disparities in testing and educating and advocating for Black communities to reduce COVID-19 infections and deaths. and she's helped over 100,000 people get testing and vaccinations. And so in my own experience, representation for engagement and dissemination matters. As Dr. Mascatia mentioned, I was the only Latina on the Health Equity Response Task Force and the only pediatrician. So I spent a lot of time during the early days of COVID-19 discussing with Latino populations on a lot of virtual formats and virtual platforms why it is that it's important that Latinos get that they do social distancing, wear a mask, etc., dispelling a lot of the disinformation that was out there. I did a lot of talks on vaccinations in English and in Spanish. I did it in the United States. I did it in Brazil, and I was able to speak on various press conferences about updates on things for children and updates on kids in terms of vaccines, in terms of what was being recommended, and in terms of advocating for a lot of these policies in schools. And so even as a subspecialist, I'm a pediatric cardiologist, and even in that role, I was able to inform some of these things because as a Latina and as a pediatric subspecialist, I was able to play a unique role in this dissemination and engagement effort. And so it's important to recognize that subspecialists can play an important role in these spaces as we just described. So I wanted to talk a little bit about the research that's being done in subspecialty pediatrics to reduce pediatric chronic disease inequities. And I wanted to talk about some of the tools that can be used to improve subspecialty work in DEI. So one of those is collaborative partnerships for richer data. And so I work with a lot of sociologists at Rice University, and together they have an interest in understanding how neighborhoods inform health outcomes. And they wanted to know, do neighborhoods inform worse health outcomes? Depending on where you live, your outcomes are better or worse, or you have more obesity, or you have worse asthma. Those are some of the things they had interest in. So as a pediatrician, I worked with them on these initiatives, looking at neighborhood effects and things. And then in a collaborative spirit, they worked with me on looking at obesity and pediatric congenital heart disease and the role of age and disease severity and sociodemographics. So this is a study that I did with them, looking at kids ages 2 to 17 years from 50 outpatient pediatric clinics in Houston. And what we found was that children with congenital heart disease had a higher prevalence of obesity if they were older and male and African-American and Latino and publicly insured. We also found that if you had simple congenital heart disease, that you had the same odds of obesity as children without congenital heart disease, which we thought that was a part of our hypothesis. But here's what was novel. Children with moderate or complex congenital heart disease had a substantially lower odds of probability of obesity. You can see that on the y-axis, and you can see age on the x-axis, and the gray line is complex congenital heart disease. And as you can see, while they started out having much lower probabilities of obesity, they caught up. And so a lot of what we push in congenital heart disease is you need to gain weight, you need to gain weight. We focus so much on weight gain that ends up being the mantra of the families. And then these children end up catching up and having similar obesity rates to those in the general population. And it's really, if you're going to be a single ventricle patient, it's really not great to be obese on top of that. And so work with them has allowed for this type of research, richer data. Collaborative partnerships with epidemiologists in national databases is also allowed for greater and richer data in subspecialty, in my field of subspecialty congenital heart disease or pediatric cardiology. So this is a study that myself and some colleagues, as well as a really brilliant epidemiologist, Dr. Jason Salemi, did using a national database, the WONDER database. And we looked at the worst possible outcome, which was death due to congenital heart disease across the lifespan. And we wanted to see if there were still racial and ethnic disparities. And the answer was, over the 17-year period, while it was great that overall mortality decreases, you can see there on the x-axis, between 1998 and 2018, and on the y-axis is the age-adjusted CHD mortality rate, it did go down. However, you can see that the blue line represents non-Hispanic Blacks, and they still had higher rates of mortality across the 17-year period compared to non-Hispanic whites in the black line. Latinos had similar rates of infant mortality compared to non-Hispanic whites, but you can see there that the red line for Latinos actually ends up plateauing around 2009, while the rate in non-Hispanic whites continues to decrease. And so there's been a plateau in that population. And so our collaboration with epidemiologists has allowed for this greater and richer data. Multi-institutional collaborations also are what help us in subspecialty pediatrics to do DEI work. There are such low numbers sometimes in a singular institution of our disease processes that in order to see bigger impacts, it is really important for us to do these multi-institutional collaborations. So this is a study that I participated in with 21 Fetal Heart Society Research Collaborative institutions in the United States, in 1,800 fetuses that had hypoplastic left heart syndrome and detransposition of the great arteries. And we looked at whether socioeconomic status, public insurance, race and ethnicity, rural residence, and distance of residence or distance to a cardiac surgical center were associated with prenatal diagnosis and the timing of a prenatal diagnosis. And when indeed, what we found was that if you had a lower socioeconomic status, this was associated with a lower prenatal diagnosis in hypoplast and transposition patients, 22% lower. If you were Latino, you were 15% less likely to have a prenatal diagnosis of a DTGA. If you lived in a rural area, you were 22% less likely to have a prenatal diagnosis of a TGA. And if you were of a lower socioeconomic status, lived in a rural area, and had public insurance, all of those things were associated with a late prenatal diagnosis. And so working together, when you're able to work together, you're able to see some of these trends and kind of then decide what type of an impact or intervention you want to do that can be applicable not just at your own institution, but all the various institutions that participate in research of this nature. Finally, examining the role of the social determinants of health in subspecialty pediatrics is critically important. As we discussed, the social determinants of health play a huge role in outcomes in pediatrics. And so this is a study by a colleague of mine, Shab Pavandi, who's at UCSF, and she's a brilliant researcher. And she did a study looking at the socioeconomic mediators of racial and ethnic disparities in congenital heart disease outcomes. This is a study from California, so she did it in the state of California. And she looked at outcomes for hypoplastic left heart syndrome patients and DTGA patients, and looked at outcomes of mortality and unexpected hospital readmissions in the first year of life for those that have congenital heart disease. So she wanted to say, what was the direct impact of a maternal race on those outcomes versus the direct impact of some of the social determinants of health on those outcomes, on those poor outcomes? And what she found was that while maternal race explained about 38% of these poor outcomes, the bigger explanation of these poor outcomes came directly from the mediation of the social determinants of health, including maternal education and insurance status. In other words, as compared with non-Hispanic whites, Hispanic ethnicity explained only 38% of the poor outcome, whereas the remainder, or 62%, was explained by these mediating factors. So this leads me to one of my biggest points of this entire talk, and frankly, if you take anything away from this talk, please take this away. Race is a social construct. It is not inherently linked to worse clinical outcomes. So when we use race and ethnicity as quantitative variables in medical education and research, we need to use race and ethnicity to represent social experiences and not biological facts to explain the phenomenon that we are seeing. And we need to report beyond simple statistical significance, including considering structural racism, as we discussed, the social determinants of health, as well as things like implicit bias. And this just in, please keep an eye out for this paper. This paper will be published soon in the Journal of the American Heart Association. And this is a scientific statement that I chaired with a bunch of other brilliant individuals addressing social determinants of health and mitigating health disparities across the lifespan in congenital heart disease, and talks directly to the heart of some of these things that we've already discussed. So lastly, from a research perspective, interventions addressing the social determinants of health can play a huge role in these subspecialty populations that we serve, and are things that we as subspecialists should really focus on in pediatrics. So this is a grant that we received with a group of four different subspecialty pediatricians, an infectious disease specialist, a hospitalist, an academic pediatrician, and then myself. And we looked at a randomized control trial of what can we do to actually connect individuals that have CHIP type insurance with that have food insecurity with the food bank. So we worked with our EMR and community health workers within our electronic medical record and our health plan to identify these patients. We found about a food insecurity rate of about 38%. And then all of us together worked to then connect these individuals and make connections with the food bank such that the onus is not on them. The food bank actually contacts them to address their issues and find ways to get them food, as opposed to putting the onus on the patients. And this project has been so successful so far that we actually broke the food bank. They had to hire more people because of the number of referrals that we had for them. And this speaks to the importance of community and healthcare industry partnerships to impact some of the social determinants. Lastly, I wanted to focus on this work by Dr. Kira Bona. She's a really amazing disparities researcher out of Boston Children's. She's a pediatric hematologist oncologist. And she did a retrospective analysis of 370 kids with high-risk neuroblastoma, one of the most common solid tumors in childhood, and who were treated on a multi-center clinical trial of targeted immunotherapy. All of the kids were treated exactly the same, and her study looked directly at the impact of poverty on outcomes. And you can see here in this Kaplan-Meier curve that those children on the red curves demonstrates those that were not poor, and the blue curve demonstrates those that were poor. And so when you looked at just the impact of poverty on disparities on kids that were treated exactly the same clinically, you can see that there was a 25% difference in event-free survival in terms of relapse and in terms of dying. So even when treated exactly the same clinically, there was a 2 times higher likelihood of relapsing and a 3 times higher likelihood of dying if you were poor. So a lot of the work that she's doing now is looking directly at the impacts of the social determinants on outcomes and treating the social determinants to see if that improves long-term outcomes of chronic disease populations. Incredible work. So now, how do we then take all of this information that we learned to translate this and to translate your voice into health policies that reduce pediatric health inequities? Well, first, I'd like to say, as evidenced by Dr. Rachel Levine, as we discussed, representation matters. And these are just a few quotes from an African-American mom, Dr. Tawana Nishibayashi, who is a parent of a child with congenital heart disease. Her child has had at least 5 open heart surgeries. And this is what she had to say about representation in a subspecialty space in a pediatric hospital. She said, "The onus is on me to actively dispel stereotypes daily in one of the most stressful and traumatic experiences that one can go through repeatedly every hospital stay, every new fellow, attending, or medical staff that I encounter. Racism happens in hospital settings as in life every day. Seeing someone that you and your child can relate to helps make you feel included. Representation is important, and it matters to see someone who looks like you for a variety of reasons, to inspire comfort and understanding, and maybe you don't have to fight quite as hard." And a lot of what we talked about in the past in terms of medical mistrust, in terms of understanding how to disseminate information, in terms of community engagement, all speaks to this. The reality is that racial bias still infects the doctor's office. And there are several studies that demonstrate that who one's medical provider is can change patient outcomes if you're from a community of color or for whom English is not your first language. So not being able to adequately communicate with or ask questions to your provider. So say, for example, if you're on rounds and the little instructor phone is not working, or the interpreter can't be there because you're with somebody else, well, now that parent can't communicate or can't participate in rounds to try to advocate for their child. The same thing is true for when concerns are not being taken seriously because of the color of your skin that may impact your outcomes. And we've seen this in maternal mortality for Black women in the OB space. Finally, not feeling comfortable to speak about certain issues because you're from a marginalized or historically disenfranchised population, such as the LGBTQ community, can certainly impact how you interact with the medical system. So if we're looking for institutional policies that can make a difference, thinking about diversifying the leadership and the mission and goals of the institution is hugely important. Improving underrepresented in medicine resident, fellow, and faculty recruitment and retention. Having implicit bias training and probably more importantly, microaggression training. And if you haven't learned about microaggression in medicine, I would encourage you to do so, because it's hugely important to how people experience medicine, not only as patients, but also as physicians of color. And then the health and digital literacy recognition is important as well. Ensuring appropriate language services and parent support services, ensuring community participation in the design of the research, not just when you've designed it and now you want to include people, include them in the design and in the delivery strategies of this research findings. And of course, social determinants of health screening. If you don't know where someone is starting, it's hard to know how to help them. At the systemic level, improving minority medical pipeline and race training, and by race training, I mean understanding that race is a social construct and not only reporting race when you're looking at outcomes. Diversifying journal editors and academic societies. Who decides what gets published? Who decides what gets funding? And who are making those decisions? Are the people making the decisions, do those people have a DEI lens? Is there representation at those levels? Improving pipelines to ensure lifelong care for populations that are chronic disease populations that are getting older, like congenital heart disease. Improving the transition and transfer to adult care for these chronic populations. And improving transparency in data. So people, not only are we collecting the data, but we're also giving the data to populations so we can understand better who is getting referred to lower performing hospitals, what information is actually available to these individuals so they can become informed, et cetera. If you haven't seen this series of articles in Race and Medicine in the New England Journal, I would highly encourage you to do so. It's free and open access, and you can really learn a lot about some of these interactions and interplays that we've discussed. This is just an example here, misrepresenting race, the role of medical schools in propagating physician bias. One example of the many articles there. There are interventions that we can do to increase recruitment and retention of underrepresented minorities, not only in pediatrics, but also in pediatric fellowships and subspecialties. So this is something that they did in adult cardiology. They did this multi-pronged initiative to try to increase the number of women and the number of underrepresented minorities in their fellowship space. And this is an incredible study. You can see that the lighter colored bars here are when the intervention actually occurred. And if you look at the x-axis, it's the years of matriculation, and the y-axis is the percentage of individuals. So in that first blue graphic, you can see that once the intervention began, they were able to increase substantially the number of women that they recruited. The same thing was true in the middle panel there of underrepresented minorities. And if you look at the change that was made after they did this really kind of investigation of how they were looking at fellowship candidates, including how they were recruiting them, what the screening process was, what their interview day was like, how they ranked them, and post-match interventions, they were able to increase the number of women and minorities from 27.8% to 66.7%. So there are things that we can do. And in fact, when we're talking about equity in the subspecialty space, I've been working, I was named the American Board of Pediatrics Paul Miles Fellow for quality improvement work in health in DEI space and health disparities. And we talked a lot about what does it mean to have DEI in terms of representation in boards questions. What do board questions mean, and who is it serving? Are you asking the board questions to trick people, or are you asking board questions to ask them what people actually really need to know? And since then, we've been talking about what happens if you fail the boards, and what things are in place to help individuals who fail the boards if the goal is to have more board certified pediatricians. That's particularly true for underrepresented minorities who tend to historically do worse on standardized exams, and what can be done to intervene on that. And so since then, they've been doing a lot more work in the DEI space, and more to come on this, but it's an exciting time to work with the ABP. Finally, reducing pediatric health inequities at the state level. We need to access chronic disease care across state lines. So if you live in a state that doesn't have great, for example, congenital heart disease surgery, it would be great if you could cross state lines and get paid, that Medicaid can get paid at the same reimbursement rate as another state, because you can't access the same quality of care in the state that you live in. Reimbursement for transition medicine services. Right now in the United States, transition medicine is not reimbursed because it's folded in under the umbrella of the operational costs of the hospital. Improving school policies for kids with chronic diseases, increasing federal level policies in terms of protection for kids with pre-existing conditions under the Affordable Care Act, making sure that stays in place for kids with chronic disease. Modernizing how to stay on public insurance, improving access to mental health care, increasing funding for fellowship slots. That's something that I'm actually going to be doing in Washington next week, is talking about why is it that Medicare funding for residencies is only for residencies and not for fellowships? Why do we have to scramble for funding for fellowships? That makes it harder for underrepresented minority individuals to actually become subspecialty trained. And then finally, funding research and programs focused on reducing health disparities. If you wanted to take a look at some of the policies that we've been focusing on in terms of healthcare policies in congenital heart disease, this is a paper that was published in the Journal of the American Heart Association with myself and a bunch of other pediatric cardiologists, as well as some cardiothoracic surgeons, looking at what are some of the policies that we should pay attention to that can move the needle in the DEI space and subspecialty care. And this is just an example of some of those things. So at the end of the day, you cannot be afraid to speak up and speak out for what you believe. You have to have courage, raw courage, according to Representative John Lewis. So if you see inequities, you should question them. You should say something. You should do something. You should research and advocate and change outcomes, even as a subspecialist. You should use your voice for good trouble. And with that, I'm happy to take any questions.
Thank you so much, Dr. Lopez. As always, such an inspiring talk and educational talk about the impact that we can all have as general pediatricians, as subspecialists, as anyone in our space. We have a few minutes for questions. I'd invite folks to plug questions into the online Q&A tool. And as those come in, perhaps I'll just touch on something very quickly. Would you mind describing for us just very briefly your work on transition care and how your work on transition care, particularly using the handheld application that you guys devised, could potentially reduce the disparities seen in transition care?
Thanks for that question. So we noted in terms of a disparity space that a lot of attention was being placed on neonates and kids early in the congenital heart disease space, and more so on adults, but very little on teenagers. And so in order for teenagers to become well-informed adults, they actually have to know the disease processes that they have and become empowered to speak up and learn about what their disease process is, how to stay on insurance, what skills they need to become good adults with congenital heart disease. So we started a program at Texas Children's in transition, and we have dedicated transition team, a nurse and a social worker, to directly address some of the disparities that we were seeing in terms of outcomes of loss to follow-up in patients. And what we found in our program was, if you did not participate in our program, your likelihood of care retention or staying in care was about 28%. In participating in our program over the last 4 years, we looked at our data, and people who participated in our program, their loss to follow-up rate, or their retention rate, I should say, was 86%. So we were able to retain substantially more patients just with a simple intervention. And because we cannot do inpatient transition services for everyone, I'm now working with the NIH to develop an app for transition based on what we've done in our clinical space to try to give it an application that gives the same type of information. And it's a tailored application because congenital heart disease is many different diseases for patients that have the inability to have, say, for example, an in-person transition program, and trying to work with them in that regard. And so it's been a real joy, kind of a real journey to work with teenagers who are very, very honest about things that they do and don't like, and can give a lot of insight into how to make them better adults to survive longer with congenital heart disease.
Yeah, teenagers can be fantastic self-advocates. That's without question. Dr. Leibowitz made a comment about the Willowbrook studies on hepatitis with human experimentation. I recommend everyone to sort of look up those studies that are part of the terrible history that we have with poor experimental practice on disadvantaged populations. Dr. Gail Wright asked about what specific recommendations have you made for placing health equity at the centers of learning health networks efforts. So I think it's a lot of the registry and health networks studies that are going on. What specific recommendations have you made to place health equity at the centers of those efforts and on specific interventions for CHD patients?
So as far as that's concerned, it really comes back to who are you designing these studies for, and who are these studies meant to, or not just studies, but who are these collaboratives meant to help? And if the answer is it's meant to help the patients and the populations that we're serving, then community participation and community-based participatory research is key. So involving individuals from the very get-go, when you're thinking about collaborations, approaching individuals in the ICU, kind of understanding their needs, approaching individuals before they get lost to follow-up, approaching individuals and imparting on them the importance of participating in these collaboratives to make sure that these collaboratives are inclusive and diverse and represent all the populations that we're serving. That is probably the most important thing that one can do, and the most important DEI voice that I have been in these spaces, describing how it's great if you have these collaborations, it's wonderful, but if you're not having representation, not only at the level of individuals who are trying to impart this knowledge, but also at the individuals who should be receiving this knowledge and getting this knowledge disseminated back to those communities. If you don't have them involved from the get-go, that's going to be very hard to do.
Thank you so much, Dr. Lopez. Dr. Chamberlain also just had a brief comment about the choice between a career in subspecialty pediatrics and advocacy, and supporting your assertion that that's a false dichotomy and that advocacy goes way beyond general peds. And with that, I think we're beyond time. Of course, you're such a dynamic speaker. There's, I'm sure, a lot more that we can talk about. We can spend the rest of the day talking about it. Thank you very much for your work. Thank you for your advocacy, and thank you for joining us today.
Thanks so much for the opportunity.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.